Hello friends, my name is Siddharth Joshi, Assistant Professor LJ Institute of Physiotherapy, Ahmedabad. Today's our topic is ulnar nerve palsy. It is very important topic for final year and third year both because in third year they are mostly used to ask in electrotherapy too, and ulnar nerve palsy is also asking in final year also. After that they are asking in rehab paper also and PTMS paper also. So ulnar nerve palsy is very vast topic and it is very frequently asked. Plus, in day-to-day practice, in prior clinical practice, in home visit, mostly ulnar nerve palsy patients you will see more. There are frequent type of patients, but ulnar nerve palsy patients, number of ulnar palsy patients are more. So this video is very useful in future for students also and clinical practitioners also. So let's start today's point. Ulnar nerve palsy, most important because frequently asked in university exam in third year and final year in various subjects for 8 marks or 7 marks both. So, ulnar palsy. First, we should concentrate on causes. What are the causes? Any condition you start, first you should know what are the causes, because sometimes when you solve the cause, automatically symptoms will go. So let's start causes of ulnar nerve palsy. At cervical spine, there are chances of due to PIVD, osteophytes in CS. CS means cervical spondylosis. RA of cervical spine means rheumatoid arthritis of cervical spine. At the base of the neck, there are chances of cervical rip and TOS. TOS means thoracic outlet syndrome. So these are the causes of ulnar nerve palsy. At the arm, see, they are taking from proximal to distal, so you can understand what are the causes and what are the root cause of ulnar nerve. So at the arm, tourniquet palsy, leprosy maybe, and humerus fracture also the reason. After that, at the elbow, tardy ulnar nerve palsy, elbow dislocation, medial epicondyle of humerus. These all are the reason or causes. At the forearm, VIC means Walkman's ischemic deformity, tight plaster. At the wrist joint, class cut injury, compression through the canal of Guyton, fracture carpal bone and tumors. These are the causes. Now, what are the signs and symptoms? This is very important because without sign and symptoms, you can't understand or you can't diagnose the condition that this is the ulnar nerve palsy. So signs and symptoms. First one is very important. Patient will come with typical complaint of sensory loss. It is very typical complaint. Sensory loss over hypothenar eminence, medial 1.5 finger. See, before you judge or before you diagnose, one should remember the cause of ulnar nerve, because without ulnar nerve course, you can't identify. Some physiotherapists don't know exactly course of ulnar nerve also, so they are confused whether it is ulnar nerve palsy or anything else. Motor loss, FCU, medial half of FDB, hypothenar muscles, interosseous muscle, medial to lumbricals, and adductor pollicis. These are the motor loss will happen. Then deformity occur. Deformity means permanent problem. Claw hand. 30-degree hyperextension of MCP joint of ring and little finger, 25 degrees of PIP flexion, and DIP joint may be flexed or extended depending upon the level of injury. So these all are the deformity typically presents in the ulnar nerve palsy. Then ulnar paradox. With lesion at the elbow, reduced flexion at the DIP joint due to the paralysis of FDP, flexor digitorum. With reinnervation, flexion of DIP will increase, giving an appearance of increased deformity, although it is a prognostic sign. So there are signs which can give you what will be the prognosis. So it is also important that prognostic sign is good or bad. Then functional deformity also occurs, that is lack of lumbrical grip or intrinsic plus position. Power grip is affected, pinch power reduced, spherical grip is lacking, and lateral pinch is inefficient. See, these are the words you should remember. Then trick movements may be present. Due to the lumbrical paralysis, extension of IP joint is possible only with MCP flexion. Due to the introsci paralysis, patient will try to abduct the finger, abduct outside the finger with ED, and adduction of finger by substitution of long finger flexors. Okay, so long finger flexors also adduction. Ulnar deviation of by ECU. Wrist flexion results in radial deviation due to FCR. Reduced tendency to go to radial deviation is the first sign of recovery in injury at the elbow. And Foreman sign is positive. See, it is very important sign, and one should check repeatedly for this sign whether it is working or not, or it is positive or not. First sign of recovery following injury at the wrist is increased adduction attitude of little finger, because ADM is the first muscle to recover. So first muscle recover give the first sign, okay, this is the working. Now go for management as usual. IG stimulation, passive movement to prevent muscle properties, stretching to prevent deformity, care of the anesthetic hand, splintage, Krunkel blender splint, volar supported MCP joint, dorsal supported PIP joint, and metacarpal bones. See, in IG stimulation is very important, otherwise it is okay, but IG stimulation one should know very perfectly. And tender transfer, this is treatment by the orthopedic surgeon, that is branch transfer, Royer-Rodner's technique, or Bunnell's surgery. So these are the treatment given by orthopedic surgeon. And for physiotherapy, you are supposed to go for IG stimulation, passive movements of every on each and every joint, stretching to prevent to prevent deformity, to prevent muscle property, care of the anesthetic hand to prevent further injury. Thank you.